disruptive technology, so you're all here to talk about how disruptive technology is going to impact the future aging. And I would like to start by kind of painting a slightly dystopian future, which I would like you to pick apart and analyze. And so when I look into the future of old age, and I imagine, my whole house surrounded by these things that are monitoring me. They know when I poop. They know when I don't. They know when I'm a little bit depressed. They can ring a robot to come round and maybe bring me a seal to stroke. And at the same time, I know at the moment I can't even operate my TV without the help of my kids. So I'm going to be captive by this techno-utopia of the future. And it's, am I going to be hacked? How much privacy am I going to have as an old person? So tell me that my old age is not going to be this absolute nightmare. Would you care to start?
I'll jump
David.
into that, since we're engaged in looking at broad new solution sets in the area of bringing not only digital health, but technology in general, across the entire continuum, from wellness and aging to end-of-life care. And one of the things I think we are in a perfect position to look at in this space is that... Can you use the microphone?
Oh, I do, that's my job, sorry.
Thank you.
Please use the microphone.
Sorry if you couldn't hear that. Once again, I believe that where we are at this point is at and you're going to hear a number of wonderful presentations here, different specific solutions, as well as the ways these can be linked into the longevity economy over the balance of the day. But central to it is going to be to avoid this dystopia. We're now at the point where between the way we're going to be creating new platforms to connect all these technologies, new form factors, whether it's voice, embedded sensors, non-touch sensors will work, and the way we use machine learning, different types of data analytics, we will be in a different position in just the next few years in terms of how technology will, in a sense, really be a game changer. It will be transformative for older adults who will no longer have to interact at the same level. So the future is quite promising in this area in terms of how all of these technology solutions will come together to create a seamless, uniform way that will not require as much engagement, but will actually take advantage of the rapid advancement, the lower costs of new sensors, devices, et cetera.
Sonya.
So repeat the question again.
Am I going to spend my old age in a nightmare dystopia of being completely monitored and have no privacy and be open to hacking by sort of, Russian bored teenagers who'd like to, I don't know, prevent me from going to the toilet? I don't know.
I think I could say a few things, but I will focus on one thing. I think it really depends on some of the investors' thesis and some of the things that they believe in and the mindset. So we're all crazy about data, and monitoring and sensors. Well, let's not forget the hope, joy, peace, and happiness that our older adults are longing for. And so companies who are focusing on that, we need funding from investor community so that we can actually focus on your happiness, instead of these sensor-driven data, because you're just being monitored. But who's working on your happiness? That's
right.
What I would like to say.
Well, we'll talk about that thing you have in your lap in a little bit, but I want to just get, Tom, your response to sort of my dystopian fears.
Yeah, well, so I know techno-utopianists. I have some of my best friends are techno-utopianists. I've spent a dozen years at Wired drinking the Kool-Aid of that, and in some sense encouraging those dreams. I think my the other hat that I've worn though is steeped in the world of public health, where it may be this audience, and as a business, it might be full of the list of things you did. Virtual reality, all these kind of sensors, which I have, again, evangelized. But when I think about what the technology is that is truly going to revolutionize or address the aging, not just the business of longevity, but the problem of longevity, I think it is much more pedestrian and much less glossy. I think it is about getting, it's mainly about a distribution problem. It's logistics instead of enhancements. It's how do we get the right intervention to the right people at the right time. I try to think of it as, as much as there's amazing science. The folks that were up here in the previous panel are on the vanguard of where this is going to go. I'm much more, I'll leave the science to them. I'm much more of the school that we know a lot of things that could improve both longevity and the quality of life for people as we continue to age. It's really a matter of getting that to the most people at the right time.
So some of the interventions you're saying basically could be a lot more low-tech than, say, virtual reality?
Yeah, or not necessarily low-tech, but not necessarily the sexy tech. It is data. It's understanding what happens not just with massive populations, but subpopulations. And I think that's the kind of the hard work that we still need to do to understand that.
Sure, go ahead.
If I could just, and I really couldn't agree more with Tom and Sonya on those points. One of the things I think that we have to consider very much is the channels that we do get technology to individuals. If we are not looking at the large-scale solutions, those scalable solutions, sustainable, but solutions that can be customizable, as you're suggesting, to individuals, we are going to have a very difficult time. But it also has to result in actionable data so that individuals, whether it's the older adult themselves or family caregivers or providers, can actually use it. So those are really underlying principles that I think are going to be central to the selection and identification of the most successful strategies going forward.
So Sonya, I have to ask you about your that thing on your lap, which I suspect has something to do with the fact that you are working in VR. Could you tell us a little bit more about that?
Sure. So we created Aloha VR some time ago when I was fighting social isolation in elders. As you know, we have 44 million seniors in the US. That number will double the next 25 years. It's a silent epidemic, as Oprah would say, loneliness. And I was speaking about Human Kindness Program 1.0 at an assisted living in San Francisco some time ago. And one of the audience raised his hand and said, I love what you're doing, giving authentic human connection through your care call plan at One Caring Team. But what about my mom? She's got dementia and she can't communicate with your caring listeners. What can you do for us? So that was a homework assignment from a new potential customer. So I said, well, let me see what I could do. I discovered virtual reality some time ago in San Fran and decided to play with it with my own experiment with my own private practice patients when I was making house calls in the Bay Area. And I had phenomenal results from some of these patients who had chronic complex conditions, including CHF, COPD, and dementia. And so I decided to go bigger and work with assisted living facilities, and that's how we created Aloha VR, and now we're working with a number of accounts in the San Francisco Bay Area. What we do is we bring beautiful worlds from outside and bring to the homebound and facility-bound seniors who can't move that well because they're in a wheelchair, who can't travel anymore because they're in a wheelchair, or they have dementia and they're in a locked-up unit. So that's what we do.
That's absolutely fascinating. I mean, what kind of results do you get?
We've been collecting all kinds of clinical data. We haven't published anything yet because.
But you can give us an idea, right?
Sure. So one of the many metrics that we're looking at is how well they eat and how much they're willing to move and how much they're willing to interact with their peers and caregivers. Looking at engagement potential index, we're coming up with our own proprietary index system, all about wellness and proactive care.
Okay, well, that's great. I wonder if each of you could reflect on, I mean, we had that poll question before about what innovations you thought would be the most disruptive in the aging market. I wonder if you could each kind of answer that question. You don't need to limit yourself to the answers that were given, but what do you think, and your time frame would be maybe 5 years, I guess. Do you want to start with that, Tom?
Sure, well, I would say I think the most promising are probably sensors and data. But but again, I'm sorry to be so unsexy, but when I think about sensors and the aging population, I think about like the sensors that exist in nursing homes right now, right? There are these alarms that clip onto older population as they're sitting in their bed, and as they move or if they fall out of the bed, the alarm goes off, right? Well, it's a great idea, but they don't really work very well because people are constantly moving, shifting, and those alarms go off, and there's a huge false signal. right? So that is, we have to think about that as the very simple kind of sensor that even that we can't get right. Think of hearing aids. It's a very simple kind of sensor. It is a horrible technology. People spend thousands of dollars, $5,000, $10,000 for a pair of hearing aids, and they don't work. Now, finally, just in the last couple of years, we're starting to get innovation in hearing aids. Well, they can't call them hearing aids because they're highly regulated as hearing aids, so they need to call them other things. But we're finally getting some disruption in that industry. But I think these are the kind of what to me are low-hanging fruit, but the very real problems where if we instead of thinking about maybe the future of medicine, we just think about the medicine that we've been trying to do for decades now, and how can we bring current technologies or current vanguard of technology to getting those problems, fixing those problems and getting that right.
Okay. Anyone else have any thoughts on what's truly disruptive in the aging market?
I run a medical VR company, so I think virtual reality is truly disruptive.
Other than medical VR.
When I introduced our program to all kinds of senior facilities, they had no idea what virtual reality was. They had no concept of it because people in virtual reality don't really think about senior care, and senior care people don't really think about virtual reality. There was just a big gap. And so when we started introducing virtual reality, people were just amazed. And the seniors, I mean, we just launched at another site yesterday, and people start to dance. I mean, what kind of medicine do you get to prescribe and you start seeing patients start dancing and singing? And that's what we saw yesterday. And my customer is actually sitting in the audience today. I mean, I'm a physician. I'm a board-certified ER physician. I've taken care of over 40,000 patients in my career, 20 years in healthcare. I've never prescribed a drug where my patients start standing up and dancing. Virtual reality, they're dancing. So there.
Well, I'd like to jump back and actually reinforce what Tom was saying and challenge Sonya a little bit, because I do think data are gold at this point. Data are going to drive this, data analytics, and it's how we get it. And the next generation, over the next 2, 3, 5 years, are going to be not only VR and AR, augmented reality, going to be Internet of Things, going to be mobile solutions, remote solutions, going to be autonomous vehicles. These are going to occur in various new ways, but it's going to be the data behind them that's going to be actionable, and we're going to be able to control it. Machine learning, artificial intelligence, and deep learning within these areas. What's very exciting, though, is to see how fast these things are changing. Tom just raised a wonderful point about hearing aids. We have major issues that are keeping people independent, or that you do not stay independent, just in physical function and different sensors, hearing, vision, et cetera. Well, hearing aids, very fortunately, this morning, the FDA and the White House just announced a breakthrough in terms of now promoting and going to open the door to over-the-counter hearing aids. Changing this remarkably. This is a game changer in terms of the cost point of how personal sound amplification devices and other formats are going to be available, which really changes the game from the 6 major companies in the world providing these to now opening up all new sorts of technology solutions. But it's still going to be the data that are collected, how those are sent to individuals, and how that helps individuals change the world and how they interact within the world.
Can I just jump in, because it reminded me of something that I've spoken of with some friends at Omada Health, which is a pretty cool company here in town. We've talked a lot for most of the 90s and 2000s, we talked about the digital divide, this problem of getting people access to digital technologies. And I think actually the more acute problem now is what we could call the analog divide, which is giving people access, getting people actually to the points of care, getting people to the places and to the services that they need, and that is largely an analog problem, right? It's one of when somebody has to get to a doctor's appointment and they don't have a car, and they're going to have to walk to the bus and then wait for the bus, and it's going to be a 2-hour ordeal just to get to the clinic to get fitted for hearing aids, say. So how can we use technologies and sensors and even VR to, in essence, to address the analog divide, the problem of access, and the problem of getting these things to people. And I'm going to be a broken record on it, but I think that, to me, is the most promising application of data, is thinking about the rather pedestrian, sometimes literally pedestrian problems therein.
I'd really like to reinforce that point, because it's the digital divide, it's equity that we're still dealing with, access to these technologies. Perfect example to pick up on what Tom said is what's been created here in San Francisco, the San Francisco Aging Tech Council, public-private partnership with the mayor's office, multiple companies, a large number of NGOs throughout the city, with an underlying principle of increasing the way individuals, older adults and persons with disabilities can get access to new technologies. If you can believe it, within the most tech-savvy city, one could say, in the country, or maybe even the world, within a 2-mile radius, we have 10,000 older adults. And this has been through a city survey, 10,000 older adults who do not have access to broadband. So we've been working with companies, and actually in the last year, a very robust program that brought 1,000 more of those individuals into connectivity within their home with a low-cost solution. These are still, again, going to be the barriers that we have. We're going to have those of us who have the latest smart devices, connectivity, can afford it, or it's embedded in our home or our workplace, versus those who are being left behind in this area, a fundamental challenge that we need to address.
I mean, I'm struck also by how some very mundane technologies are perhaps, I think, perhaps more disruptive than some of the things that we have been talking about. I mean, one of the poll questions mentioned autonomous vehicles. But I mean, if you just look at what we have now, I mean, Uber and Facebook, to my mind, are really enabling technologies for people who are just getting a bit old. And, you know, a lot of the conversation so far, we've really focused on the needs of, you know, quite a dependent sort of old person. But in actual fact, what we're seeing more now is that you have a kind of gradation of needs, and you know, you might start needing a little bit more socialization, or you might need a little bit of support getting around, maybe help getting somewhere, and then it gradually kind of goes up to being, you know, needing a lot of support in the home, and then that's where some of these technologies perhaps could come most useful. I mean, do we really? I mean, I'm sure VR is absolutely wonderful, but do we need to be thinking about this sort of high tech? Do we need to be, as Tom's saying, thinking much more low tech about how we kind of help people age well in their own homes? Yeah.
Well, I'll jump in. I definitely think that we will be seeing solutions that will be not only our lower tech ones that can be very inexpensive, but also those that reduce the interaction and make it that much easier. Not only voice, but simple devices that will make it very accessible and have individuals be able to manage just very fundamental things. But you just raised, Natasha, a very important point as well, that we are looking across an entire continuum of individuals who are quite well, who then may have assistive or certain limitations, physical or otherwise, also moving into more complex chronic conditions all the way to end of life. Even at all of these points, we have different needs, and technology can be a solution. What's very intriguing is, since we know that the longevity economy, as AARP has said, is a $7 trillion issue right now, it creates a new opportunity for individuals to stay engaged, particularly in wellness, social engagement in many different ways. And this is, so we do not need the highest of high tech. What we do need are form factors. We need solutions that are very accessible and at a price point that are also accessible to a large number of older adults, as well as their family caregivers and the provider community that works with them.
Tom, do you want to?
I just want to make a quick comment that, you know, having worked with seniors since the mid-90s, I think, in my humble opinion, the best thing for seniors who's living alone at home or assisted living is having their family member or their daughters or son visiting them as frequently as possible. We all know, you know, that is the best thing that our elders want. Our grandmas and grandpas, that's what we want. But it's not happening. So if you take a ride to any of the assisted living here in the Bay Area or elsewhere, you will not see family members visiting the grandmas and grandpas, whether they have dementia or not. Especially if they start having dementia, people start distancing them, which is the worst thing for the family members, right? For the grandma as well as the family members. And they start developing this distance within the family, and the wall starts coming up. And that's when you start losing the Grandma Betty, who had mild dementia, and now she's gonna decline because there's no more connection to the outside world. And that's when the cognition starts declining, and when the will to live goes away, you're gonna start losing it emotionally, mentally, and physically. And that's when everything goes south. right?
That's a very striking picture that you paint.
So the best solution for our aging adults, what is it? It's your loving daughter and son. But guess what? We're having less and less children, and people are getting older and older. And yes, there's a national shortage of caregivers. So what do? We have to look for technology that will assist and address the most significantly unmet need, which is loneliness and people who want to engage with life, but they can't. They can't go out of their nursing home room, whatever. So we have to bring the world to them. And that's why we decided to use virtual reality. Not because virtual reality is sexy technology. It's because when I looked at the landscape of aging tech and market, senior market, I thought, okay, what does my patient Betty want? Okay, she's 88, she's a multimillionaire living in this fancy schmancy CCRC or assisted living in San Jose or wherever, and she's lonely and she's bored. She's bored to tears, okay? And she doesn't want to watch TV anymore. She doesn't want to play the bingo again, okay? Bingo is not for everyone, all right? Every nursing home and facility has it, but it's not for everyone, okay? She used to go to the opera. She used to go to the ballet. Well, she can't go there anymore. Her son died of alcoholism. Her daughter, who's going through a painful divorce in Las Vegas, out of the state. So she's got no one. So guess what? She stopped eating and drinking water. And she ended up in the emergency room where I used to work 3 times in 1 month and got admitted to the hospital twice, all in 1 month. And take a guess how much her medical bill was that month. Take a guess.
I don't know, 100,000?
$56,000 and counting.
I just made that number up.
That's okay. Medicare didn't cover for everything, as you know. They're covering less and less. So if you think about my patient Betty's story, what went wrong? And she's not a psych patient. She doesn't have depression. She was not on any antipsychotic medicine. She's just an older lady who had no one to connect with. And she used to travel a lot. And so I started doing a lot of VR with patients like Betty, and their world is different. Their world is transformed.
Right.
And so that's why we're looking at technology like virtual reality. Not because,
it's cool.
This is sexy.
No.
But I started solving human problem in a most efficient, effective way. Having been in Silicon Valley for a few years, I thought, okay, well, let's do this.
That's a good answer.
And just if I could follow on that and clarify, so I'm not advocating low-tech solutions. I'm not saying that high-tech is useless. What I'm rather trying to point us to are what I would call basic needs. So the problems are very simple. The solutions might actually be high-tech problems. So what you articulated is, I think, a basic problem of access to love and empathy, right? And we need that as human beings. We need that. That becomes scarce as we get old, and it's more difficult to access people. So using technology to address those basic needs is what I would point us to. Similarly with food, I think access to good, healthy food is a challenge. It's easier to get. We've designed a beautiful civilization to cater to our worst impulses and needs and cravings, and it is the task of healthcare to clean up the mess. What I'm proposing is that if we're addressing longevity, or we're thinking about how do we maximize the years we have, that we think about it in terms of how do we fulfill people's basic needs as humans, in terms of shelter, in terms of comfort, in terms of transportation, in terms of entertainment, and make those systems ones that contribute to health and contribute to a long life and a healthy life, rather than ones that in essence are frivolous or end up actually hurting us.
So I wanted to let you all know I'm going to open it up for questions in about 3 or 4 minutes. Please do feel free to send them in the app, but think up a few good questions. Before I turn it open, I just wanted you to think about the kind of barriers there might be to sort of introducing technology that is going to help aging. And I'm thinking payment, really. But there may be some other ones I haven't thought of. If you could all please kind of address that question, that would be great.
Well, I think a fundamental one is the issue of engaging the older adult and family caregivers and providers in the design of any new technology solution. We are now seeing through some wonderful organizations that are starting to do this, the idea of co-design, working with older adults on the design, working with family caregivers. Until we grapple with that, and these companies are doing a phenomenal job with that, until we see that with the largest companies who are working in the longevity space, we're going to have major challenges because there is a disconnect. So in addition to, obviously, the payment mechanisms and how we tie those in terms of particularly in healthcare, it really comes down to engaging individuals in this entire design enterprise.
Okay.
Barrier to entry. Well, a lot of seniors who are already depressed because they've already been neglected by their family members for many years are not willing to try anything new. So that's just the way it is. The good thing is, if you get to know them and warm up to them and you know how to work with seniors, then you can get around that. But I think a lot of young tech company who's trying to disrupt this aging market will face a lot of challenges if they don't have a lot of experience working with seniors, because a lot of seniors are not that open to new innovation unless you really know how to connect with them heart to heart. So
that's an interesting point, actually. Yeah. Tom, do you have anything?
Well, I think the barriers are rather prosaic. They are payment. So we pay to treat disease. We don't pay to maintain health. So creating incentives and systems that change that, I think, are challenging. I think CMS has made great strides over the last few years. We'll see what happens in the next administration. But I think getting the incentives lined up is going to be difficult. And then I think something that everybody hits their head against is interoperability, having the systems talk to each other, having an ability to identify whoever may, if there's a population or a patient that may be identified as optimal candidate for a VR intervention, how do you communicate that to the primary care physician neatly in a way that works with workflow that lets them do it without adding to a already stressful and overworked infrastructure? It's as I say, it's very prosaic, but until we figure out those two things, which we've been banging our heads on for a dozen years now, or at least 8 years quite prominently, I think it's all well and good to have the idea of these technologies really making headway, but people aren't going to pay for them. People aren't going to pay, for instance, when the last panel talked about metformin, and I think and the idea that metformin has all these benefits. Well, and this is something we do at my company, Iodine, we identify what is the real experience of taking those drugs, and it turns out that if you take metformin, you're likely to have diarrhea for 3, 4, or 5 weeks. And if you tell somebody, well, this drug could be good for you, it could help you avoid diabetes, but you're going to have diarrhea for 3, 4, or 5 weeks, who's going to do that? Who's actually going to do that as a preventative? I think very few people, actually. And so understanding, sorry to go on that tangent, but I think the reality is understanding how the kind of prosaic reality of these interventions actually gets the people, again, we are not going to solve anything until we solve that first.
Okay, can I see any hands? Great, lots of hands coming up. Esther was first, and that gentleman down there, and then 2 blonde ladies down there. So Esther first, and then gentleman there, and then I won't forget you two.
So I'll talk about the payment thing later on another panel, but I was listening to the talk about getting the seniors involved in designing, but then Sonya said, well, but they don't really want innovative stuff. Perhaps the Holy Grail is not what those seniors design, but the process of having them involved in design in the first place. And if you could just create lots of places where seniors go to design stuff, it could be simply a bench for their local park or something. It's not high tech and it's not scalable, but I'd love your reaction to maybe it's the process rather than the result.
Absolutely, very well said, because it really is this opportunity for people to have input, because it won't necessarily be that they can inform an engineer or they can inform a clinician and how to do it, but for older adults, for their families to be engaged in what you need, a very simple form, that has been a game changer. And we're now seeing a number of informal programs, whether it's in OSHA lifelong learning programs, whether it's in the Village Network, whether it's in, again, built right within some of the design groups that are now fundamentally, and even some of the venture firms that are looking at technology solutions, having that input from the get-go. Because ultimately, a lot of the technology we're seeing today will not be there. You have to be looking at the process and the goal of what people need, prosaic issues, rather than looking at the specific type of technology, because the technology is going to change remarkably and quickly. So how do you move from something that right now takes a device but will shortly be voice to a few years later maybe an embedded sensor that picks up on it but you need the older adult input into that process.
Okay, gentleman down there, please.
Hello, my name is Michael Perman. I have a question for Sonya. I love your perspective on the importance of joy, peace, hope, happiness. I'm wondering if you're seeing evidence on the production of hormones and neurotransmitters such as dopamine, oxytocin, serotonin, the relationship of that to long-term health and better aging.
I'm so glad you asked that question. So when we close our Series A next month, we'll do another set of trials where we'll look at all those hormone levels, because as a clinician, I mean, as an ER doc, I'm focusing on the outcome, right? I mean, outcome is, I know that that's ACA, outcome driven. Before they were spelling outcome, I was thinking outcome in my med school as a pre-med and ER physician to be. And as an ER physician, if you come into my ER with a stroke, I have only a short window of opportunity for me to save your life, right? And so I have to do whatever it takes to save you, to diagnose you when you're not talking to me, when you're totally gorked out. Excuse my language. I need to figure out what happened to you, why you're not talking to me, why your pupil's blown, why you're not moving your left hand, and be able to decide to whether to push the drug or not to drug, CT, whatever, right? And so it's all about, what do I see? What do I want to see? What's the end desired outcome for these seniors? I've dealt with tens of thousands of seniors, as I said. Majority of my patients have been seniors all my career. So I said to myself, well, what can I do as a physician entrepreneur for these ladies who have lost their husbands, because women outlive the men. So most of my patients are women. And I just wanted them to smile. That was my first goal, okay? Look, I just wanted them to be happy. All right? And so, yeah, you can talk about biochemistry and the cellular level mitochondria, all that. Yes, data is very important. And just to get back to your point, I wasn't saying that there's no value in data. It's just that I think some of the investors think that, not all, but some are just so driven by data, they're only investing in companies that's giving them data. Well, they don't understand that if you don't focus on the clinical side of aspects of things, you're gonna miss out on a lot of things. Well, how I'm going about this is, okay, healthcare, chronic care, it's costing us a lot of trillions of dollars. What can I do? Okay. Well, let's see if we can make these seniors happier. Okay, let's start there. How can we bring happiness to them? Okay, now we have something to give to them. Now we could collect some data that's meaningful. Now we can actually collect data that's meaningful, and we can take actions, right? And that's where we're going.
Okay, that's great. Sorry, I don't want to rush you. Lady there, please.
Sure. Hi. Just curious on your view on the importance of investing in something basic like the electronic medical record as a way of a really basic platform of collecting a lot of the data, right, and maybe mining it for knowledge that could be applicable.
Anyone want to take
make
that?
sense across many platforms.
What do you mean by investing? Like, who's the actor? Is it, you mean like investing in innovation in EHR?
Innovation in EMR. Are these?
Good luck in that.
Do we even have standards today that are applicable across?
There are all sorts of
the
standards,
board?
but I think there are any number of better markets to invest in than somebody who's going to try to pitch you on a new breakthrough EHR. There are lots of companies trying to do that, but then there's Epic. I think there are other places for your investment dollars to prosper.
Well, I think you're exactly right that we've missed a golden opportunity over the last few years. The Office of the National Coordinator, as we went into this over the last 8 years of really expanding electronic medical records nationwide, we had an opportunity to create those standards. We're now going into an era where regulation standards may be even harder to push through. What's unfortunate is we're now left with many disparate and dysfunctional programs. Our work in China, for example, is we're working with a few startup companies to look at EHRs and how we use data for clinical outcomes, et cetera. it's ironic because not only within each province, within each city, but each hospital has its own EHR.
Exactly. That's it.
Versus even here. Now, one of the other options we have, for example, in the University of California system, we have a wonderful group who's now merged data from our 5 UC medical centers. We have a 15 million person data identified data set where we can do cohort identification studies in minutes. But this has taken a great deal of work. It's based on an EPIC system, but it's a federated program because we don't have mechanisms to bring it together. So it is, to me, still one of the holy grails. It's if we can get to that interoperability and that connectivity, we'll make it, but we have a long ways to go.
I mean, but some of the hospitals and insurers are actually doing quite a lot with healthcare records already, and you don't kind of need to put them all together before you can do actionable things. That's my impression anyway. Lady over there.
I would just point out, as she's getting the microphone, that Stanford, for instance, a few years ago had a breakthrough paper on using EHR data for interventions. It was a really nice paper in the New England Journal of Medicine, but after they did that, the hospital changed the policy and wouldn't let them actually mine the records to do those kind of interventions anymore. So it's very, the potential has always been there, but
Yes.
the actual the impediments are, I think, if anything, growing.
And in fact, that reminds me, and Google's just had this relationship with the National Health Service, and they sucked up about 5 million health records and then got into a bit of trouble because they took too much or were given too much. I can't say which. Lady over there.
So I have a question about remote monitoring technologies. I know we spoke about them a little bit at the beginning. My question is specifically, I'm a nurse, and I see with patients, particularly those living in home either at the end of life or they have chronic conditions, we see that alarms are triggered. Some parameter is passed, an alarm is triggered and sent to whoever the person is, whether it's a nurse or whoever. And often, even if it comes back that whatever level was within sort of a normal range or okay for this person's disease and condition, nobody seems to trust the alarm still. And it's relatively simple technology, right? It's blood pressure, heart rate, weight, and something like that. That's really all that it is. And so the technology is very simple, but nobody is trusting the alarms. And so what's meant to decrease cost and decrease the amount of workforce needed isn't really having that effect. And so often things are still escalating to the emergency department or to whoever the next person in the line of command is, whether it's the nurse or the doctor, to whoever's kind of running the program. And so I'm wondering if you think that the solution is improving the technologies to make them more trustworthy, to decrease this alarm fatigue that we all seem to have, or if the solution is just time, like trust will come with time.
Okay, good question. You can see on my screen that I'm being told to wrap up, so if you wouldn't mind wrapping up and giving the final thoughts you have, that would be great.
One, just a very brief one. Our Transatlantic Telehealth Research Network that includes many hospitals in Denmark, Cleveland Clinic, Partners Healthcare, UC Davis, has been looking at these problems. You need to get, once again, it's both directions. You need a back end that creates actionable data with very limited information, and you need training. You need the front end with providers to do that. It is going to improve remarkably, but it's a comprehensive process, and unfortunately, because of the false positives, et cetera, we still have a ways to go.
Any final thoughts from the rest of the panel?
I was going to say, this is where I was going with the first comment that I made, is if there's too much data out there, there's too much noise. And, physicians, like he was talking about, we're very busy, and we don't want junk. We don't want false data. We don't want false alarm. We don't want to know. I mean, we're human. There's things that's going to, sodium could be 141 or 146. I mean, if you're off by 1 point, are you really sick today? Not really. So that's what I mean by there's a lot of limitation when you're talking to all these companies, data-driven company and all this predictive analytics. Yeah, I know all the buzzwords, but as a practicing physician and as a physician entrepreneur who's innovated in this field for the last 9 years, there's just too much noise. So investors out there, please be careful.